for our third lecture for the day, third and last lecture for the day. We have here with us Dr. Eman Nada. She is an assistant professor in the Department of Anesthesiology and Perioperative Medicine, University of Massachusetts, USA. And now, today she is giving us a lecture about...
My lecture?
Yes, regional anesthesia. It's seen on it's shared.
So I hope everybody now is having some room in their brain to hear more information after the two very rich and very informative lectures of two anesthesia giants in Egypt. So I'm taking you in a very different direction here. So we're going to regional anesthesia. So first, I'm going to talk about the anatomy and the clinical applications for nerve blocks in the upper and lower extremities. First, I want to ask, is everybody okay to start now? Do anyone need a break or a cup of tea or something like that?
I think we should go on with the lectures.
Okay.
Yes, we're happy. We're there. Don't worry.
So I will start with the simple anatomy of the brachial plexus. So as you know, the brachial plexus starts in the form of roots. The roots of the nerve start from C5 through T1, C5, 6, 7, and C8 and T1. These roots emerge into the form of trunks, and the first two roots, C5 and 6, form the superior trunk, while the seventh root continues as the middle, and the C8 and T1 continue as the inferior trunk. Then each trunk divides into anterior and posterior divisions. And then these divisions reconnect in another way to form the terminal branches. So the posterior divisions form the posterior cord, which ends mainly in the radial nerve, and the anterior divisions of the superior and middle trunks combine to form the lateral cord, which would be one big part of the median nerve, and the inferior trunk will end up as the medial cord, which shares the lateral cord into the median nerve, and at the same time continues as the ulnar nerve. So sometimes it's difficult, it's confusing to make the arrangements in your brain. So I find this picture is very helpful. So we'll start with the roots, which is like a tree. It starts with the root, and then the roots go up and form trunks. And trunks divide and form divisions. We might not be able to see them above the ground, but sometimes you can see things like that, and then they start to form cords, and then cords form the branches, which are the nerves that the end nerves that we work with. Regional anesthesia wise, we do blocks of these nerves at multiple levels. The most proximal for the brachial plexus would be the interscalene nerve block, which would be at the level of the trunks. And after that comes the supraclavicular, which is somewhere between the trunks and cords, and it's mainly in the division section. And the infraclavicular, it's also division and precords. And then the axillary division, which is the axillary, which is at the level of the cords. So now some landmarks, like it's easy to know them, and it's important to know them. Sometimes it's not easy to know every one of them, so we'll need to have some references or some milestones so we can follow them. So this is the shoulder, it's usually C5 and 6, and this is the thumb, it's usually C6, and this comes from the radial nerve, and the median nerve gives you the nerve supply of the lateral 2.5 fingers anteriorly, and the ulnar nerve on the other side, and the same from the other side, but you have here the radial nerve instead of the median nerve, although the median nerve continues and covers some of the back of the fingers. So it's very important to know this anatomy. So as I told you before, like the dermatomes, sometimes they are not clear cut as we see in the pictures, but at least you need to know some milestones. The C5 is the top of your shoulder, C6 is your thumb, and C7 is your fingers here, and C8 is your like small little finger, and T1 is the axilla. And the very known landmark or very known sign, if you give a patient a spinal anesthesia, especially in obstetrics, and they tell you that my index finger is numb, this means that your level has reached to number C6. Same thing here. It's here are dermatomes, and here's like peripheral nerves. This is the supraclavicular nerve, and these are some cutaneous branches, and these are branches from the musculocutaneous nerve, and so on. Also, whenever you do a nerve block, you have to have an idea about the function of the nerve so you can test your block. Very important to know that your flexion comes from C5 and 6, and usually musculocutaneous nerve, your extension comes from C6 and C7, and this comes from the radial nerve, and flexion of the hand comes from the ulnar and median, and extension still comes from the radial. So now we're going to go to the anatomy. So when you do the supraclavicular brachial plexus block, you have to know some landmarks here. So it's very evident that you see the sternocleidomastoid muscle here. You can feel it. You can see it in many people, except if the patients are morbidly obese. And you can feel the interscalene groove to some extent. So this is what we superficially see, and this is the interscalene groove. So what is behind that? Like this is the sternocleidomastoid muscle. It has two heads. One is the sternal head and one is clavicular head. And this is the trapezius. So this is the back one is the trapezius. Inside you feel a depression. This is the interscalene. So the interscalene, you have the middle, the anterior scalene, the middle scalene here, anterior scalene here, and posterior scalene here. So you're going to be dealing with these muscles, and the nerve plexus is going to be in between these muscles. So this is another close-up. So these are the nerves you block in the brachial plexus, and these are the muscles that sandwich the brachial plexus. So when you do an interscalene brachial plexus, you put your probe on the patient neck. In the old days where we used to do the landmark technique, we used to say, find the cricoid cartilage, which is at the level of C6. It's very useful to know that, but with the ultrasound, you might not need to do that, or sometimes still patients are obese and you cannot find these landmarks. So here you have two important landmarks to look for. So this is the anterior scalene muscle, and this is the middle scalene muscle. So you have to find the middle scalene muscle and the anterior scalene muscle, and the nerves are sandwiched in between. So when you come from the back to the front with the needle, so most probably you're going to go through the middle scalene muscle. Sometimes you have a dorsoscapular nerve here, and you can hit without even noticing it. And you go and you try to put your needle here. So you find these nerve roots. This is C5, and this is C6, and this is C7. So previously people used to think this is C6 and this is C7 and C8. Recent research has shown that this is C5 that's split, and C6, sorry, this is the same nerve C6 that is split at this level. So it's very important not to try to go in between these two branches, because if you go in between two branches and put your needle here, you might end up injecting inside the nerve itself and causing nerve damage. So if you want to do an interscalene nerve block, or the indications for this interscalene nerve block, usually it's shoulder surgery or a proximal humeral surgery. So usually this is the distribution, so it's not going to be good for anything on the medial side of the arm. Now we're going to move to the supraclavicular nerve block. So in the old days when we used to do the supraclavicular blind technique or nerve stimulation technique, we used to do to find the clavicle and then find the midpoint of the clavicle and feel the subclavian and come lateral to the subclavian and put our needle there. It's a useful landmark, but with the ultrasound, now we can see what's inside exactly, because when you put your needle, you don't know where it ends. Yes, we try to hit the rib, but it doesn't mean that it's going to cover all the nerves. So the anatomy here, if you come in the middle of the clavicle, here you'll find the subclavian artery. That's what we feel as pulse. And lateral and posterior to this are usually the nerve plexus. And they still come between the two muscles, the anterior scalene and the middle scalene. Please be mindful of the phrenic nerve. Here is the phrenic nerve, and you see how the phrenic nerve runs in front of the anterior scalene, and this is why we get the phrenic nerve palsy. So we need to be in this area, we need to be away from this area. So this is the supraclavicular block. Now we put the ultrasound above the clavicle, and we try to look inside until we find the landmark we're looking for. Usually we see something like this. So, so here, subclavian artery, this is your landmark, and this is the divisions of the brachial plexus. Here it looks nice and compact and besides each other. Sometimes you don't see this pictures. There's many anomalies, but if you like, this is the most common presentation you see it, you have to make sure that you're away from the first rib and the pleura. And with dynamic ultrasound, you can say which of which, as the pleura is movable and shimmering and glistening. And at the same time, the first rib is hyperechoic, followed by drop off after that. So when you do the, I'm gonna touch on the technique really quickly, so I don't take long time. So the needle goes from here, comes from here, and you want first to go underneath the plexus, put half of your medication, 1/3 of your medication here, and then you pull the needle back, and then you come and put half here, and you put the rest here, so you cover all the brachial plexus from each side in the supraclavicular approach. So this is the same, and this is what we call the corner pocket. This is the corner pocket. You want to cover this, because if you don't cover this and you cover here, you might end up not covering this nerve, which is the ulnar nerve. And this will be, the patient will tell you, like, I still feel my little finger. So it's very important to go in this corner and deposit your medications if your surgery entails an ulnar nerve distribution. So supraclavicular brachial plexus block gives you most of the coverage of the upper limb, and they call it the spinal of the upper extremity. Spinal means when you do spinal, you cover everything from the lower half of the body. It's the same thing here, except this area, which is covered by the intercostal brachial nerve, which is a branch from T1 and T2. This is not a branch from the brachial plexus. So if you want to do surgery here, you make sure that you make another nerve coverage, which is the intercostal brachial nerve here. And this is how you do the intercostal brachial nerve. It's actually a subcutaneous nerve, so you don't have to do sophisticated techniques here in the midline, and you have to inject medications in a ring-like manner above and below this line. So another technique is the infraclavicular technique, which we do it in the landmark, in the area of the landmark. We used to find the coracoid process and go 2 centimeters down and 2 centimeters medial, and this is going to be landmark. Now with the ultrasound, you can see everything inside, so we don't have to do this. So this is with the nerve stimulator. So with the nerve stimulator, you go by landmark and you put your needle and you stimulate the brachial plexus infraclavicularly, and based on the stimulation, you place your medications. So using the ultrasound, you can see inside, it makes it safer and easier. So what you look for is you look for, so this is a little bit a deep block. So you have a pectoralis major muscle followed by the pectoralis minor muscle. And then you look for the axillary artery, which is the subclavian. As it's progressed down, it becomes the axillary. And here is like the nerves or the cords are posterior cord, lateral cord, and medial cord, and you want to inject around this. The most important one would be to target this one, and usually the medications goes to this side and this side. If it doesn't, you have to target each cord. So this picture tries to show like there are many variations. So we always think like this should be here and this should be here and this should be there, but there are many variations. So that's why the blind blocks doesn't work as well as the blocks under vision. Another block, the brachial plexus, is called the axillary block, and it's a relatively easy block and a safe block. And but it doesn't give you the same coverage as the previous ones. It will give you something like from the mid-humeral down. So it's not good for surgeries in the upper shoulder. It's not good for surgeries where they need a tourniquet here. Simple landmarks, you need to know that the biceps is on the lateral side, and this is coracobrachialis, and this is the axillary artery, and down is the triceps. So before the ultrasound, we used to do it, like you feel the artery here. It's very easy to feel the axillary artery. You feel the axillary artery and you pass the needle and you transfix the axillary artery until the blood stops. And then when you stop aspirating blood, so you are in the posterior vascular sheath, and then you inject the medication, 30 ml of medications there. It carries the risk that you're injuring the artery. At the same time, you can inject intravascularly without recognizing it, or like now with the ultrasound showed us, there are many septi and there are many partitions between the nerves. So sometimes if you inject and you do everything right, it doesn't work really well. So the ultrasound give us another chance to be able to see this. So you put the ultrasound here, you look for the axillary artery, and when you find the axillary artery, the nerves are distributed around the axillary artery. So this is the lateral side. So you have the median nerve usually on top of the artery, and the radial nerve is below the artery, and the ulnar nerve is usually on the medial side of the artery. There are variations also. It's better to see the medications are surrounding the artery. And this is the musculocutaneous nerve, which is in between the two muscles, the biceps and coracobrachialis muscle. This is the most missed nerve. It's difficult to find, but a small trick is that you move your probe down and you'll see it better between the two muscles. So this picture tries to show the variations. Usually the median nerve is above the artery in this region, and usually the ulnar nerve is on this side of the artery, and the radial nerve is below the artery. So axillary block coverage is usually from the mid-arm down. So as we said earlier, it's not good for the shoulder, but it gives you the safety of for the interscalene, for the supraclav, there is always the incidence of phrenic nerve palsy. This one doesn't have that incidence. The infraclavicular has a very low chance of phrenic nerve palsy. So each technique has its values and drawbacks at the same time. So I'm not going to dwell a lot on this, but sometimes you need to do a peripheral nerve block to supplement your brachial plexus, or there is a small limited lesion that you can do it with a single nerve. So as we said earlier, so this is the radial nerve. It comes from the posterior cord, and it goes behind the humerus, and then goes on the lateral side and then divides into posterior interosseous nerve and then the superficial radial nerve here on this side. So sometimes if you miss the radial nerve somewhere up or somewhere, so you can target this in the pathway here. So it's very well known that the radial nerve goes onto the humerus itself and what we call the spiral groove. So you can find like the humerus, this one hyperechoic, and this is the radial nerve, and you can block it at this side. Another side, if you go down a little bit, you find it on the lateral side of the arm between the brachialis muscle and triceps muscle, and you can block it at this side. So I'm not going to spend time on this, so to save time. And the ulnar nerve, also an important landmark. It goes, as we said earlier, it comes from the medial cord and then goes behind the medial epicondyle and then goes between the two muscles here and goes medial to the ulnar artery. So here you can target that nerve at the forearm where you see the ulnar artery and the ulnar nerve next to it. You can target it here in the rest block. So this is a very easy block. It can save you a general anesthesia for small procedures in the hand. So landmarks that are easy to find: flexor carpi radialis and flexor carpi ulnaris and palmaris longus. The flexor carpi ulnaris is on the medial side, and the ulnar nerve is medial to it, and palmaris longus, the medial nerve, is lateral to it, and flexor carpi radialis here, it's difficult to catch the radial nerve here because it has branched off. And another important landmark for the medial nerve is next to the brachial artery. If you can see the brachial artery, the medial nerve is next to it. So now we're going to move to the lower extremity. So important landmarks in the lower extremity, we have the groin is T12L1. So we have to know that. The knee is between L2, L3, and the foot, we have S1 on the outer side and L5 on the front here. So two important nerves in the lower extremity are the sciatic and femoral. Add to this the obturator nerve. So all of them come from the lumbosacral plexus, come from here, and they are between the abdominal, between the psoas major muscle and posterior abdominal wall muscle. They come into L1 and L2 still in the abdomen and still until the groin, which is the iliohypogastric, ilioinguinal, and genitofemoral. After that, L2, 3, and 4 divide into anterior division and posterior division. Same nerves, anterior division gives you the obturator nerve. Same nerves, the posterior division gives you the femoral nerve. So they have the same origin. The L2 and L3 gives you the lateral femoral cutaneous nerve. As you can see here, so the obturator goes medially and the femoral goes laterally, and lateral femoral cutaneous goes laterally, and an important landmark here is the anterior superior iliac spine. So when you want to do a block of the lower extremity, you want mainly to block these two nerves. So the lumbar plexus block used to be a block that targets the femoral, lateral femoral cutaneous, and obturator nerve. However, this block is sophisticated, is deep. There are case reports of development of abdominal hematoma after this block, and it's not commonly done nowadays. So femoral nerve block is a very important block. We do a lot this block, and the distribution of the femoral nerve block is usually the front of the thigh and the medial aspect of the leg. The front of the thigh, including the skin, subcutaneous, and the quadriceps muscle, very important. And the medial side of the leg, and that's the saphenous nerve. So landmark technique, the femoral nerve, we used to find like the groin, draw a line from the pubic tubercle to the anterior superior iliac spine, divide it into 3/3, and on the lateral third, you try to feel the femoral artery, and the most lateral to the femoral artery would be the femoral nerve. And we used to do double clicks, put the medications there, and since we don't see it, we depend on the volume. If it works, it works. If it doesn't work, it might be patchy or doesn't work. So so this is the anatomy. It's very important that we know the vein is the most medial, then the artery is in the middle, and the femoral is most lateral, the femoral nerve. The femoral nerve is a big nerve and usually is flattened. So the ultrasound gave us eyes to see things that we used to do blindly. So we put the ultrasound here and we look for this. So the good thing about the regional anesthesia, usually nerves are accompanied, or vessels are accompanied by nerves, or nerves are accompanied by vessels. So our landmark, primary landmark, would be the femoral artery. Lateral to the femoral artery would be the nerve. So you see these white things, you don't know which one is the nerve and which one is the fascia. It's very important that we have to pierce the fascia, because fascia lata is the one on top, then fascia iliaca after that. Fascia iliaca is the one that covers the iliacus muscle, which is here, and the nerve is underneath. So this, we have to go through these two fascias for the femoral nerve block to work. If we did not go through these fascias, it's unlikely that's going to work, or at least not going to work well. As you see here, fascia lata, fascia iliaca, and the nerve here, and the nerve sits on the iliacus muscle. Same also, here's the femoral artery, and here is the fascia lata, fascia iliaca, femoral nerve, and we have to go through the two fascias to inject around the femoral nerve. Recently, not recently, in the past 10 or 15 years, the block that was developed is called the adductor canal, is a modification of the femoral nerve. The reason for that modification is that the femoral nerve, it supplies the muscles and the sensations to the anterior thigh, medial side of the knee, and the knee in general, and the leg. And when you block the femoral nerve, you block all the muscles and the sensations. So this became a problem, especially in joint surgeries where they want to mobilize the patients early. So the modification came that if we come down a little bit, so we avoid the nerves that goes to the muscle, and we end up targeting the more sensory nerves than the motor nerves. And this is when people became very interested in the adductor canal block. So adductor canal block is you try to find the femoral artery here. Here the femoral artery has divided into the superficial femoral artery and profunda femoris, which goes inside. And you have the nerves go along the artery. You have two important nerves here. One nerve is the saphenous nerve, which we want to target because it's sensory, and another nerve close to it called the nerve vastus medialis, which we want to target. And on the other side, you'll find some twigs from the anterior division of the obturator, and all of this are like in surround the artery. So when we go down here, we target these nerves. So we look for the blood vessel here, which is the superficial femoral artery, and on top would be this muscle. This muscle is the sartorius muscle, which is, we see it here, and this is the vastus medialis muscle. So we put our probe here. So the sartorius muscle will be directly underneath the probe. And we find the nerve, and we find the artery, and the nerve is usually on the lateral upper corner of the artery. This is going to be the saphenous nerve. When we inject this, the medication seeps around and goes and targets the other nerves. One of them is the nerve to vastus medialis, and the twigs. If we go to the other side, we can also target the twigs of the obturator and the lateral femoral cutaneous. So this is a simplified illustration. So this is the sartorius muscle, which is directly underneath, and then you see the artery, and the artery is with an artery is always a vein, and this is the saphenous nerve.
Dr. Eman, 5 minutes remaining.
Okay. So another nerve would be the obturator. So the obturator uses are limited. I'm not going to spend time because there is some more important nerves here. So the lateral femoral cutaneous nerve, the most important landmark is that it runs in front of the anterior superior iliac spine. So you can do it blindly, subcutaneously, you can do it with ultrasound. And this supplies the lateral side of the leg like this, of the thigh. And the chronic pain, in the chronic pain physicians usually block it for a condition called meralgia peristatica, which is compression of the lateral femoral cutaneous nerve of the thigh. And this is how we do it with the landmark technique. An important thing, the obturator nerve, if you want to do it at the lower level, so you look for the adductor group muscles, and the adductor group muscles here, you want the adductor longus and adductor brevis and adductor magnus. Between the adductor longus and adductor brevis is the anterior branches of the obturator, and between the adductor brevis and adductor magnus is the posterior branches. Sciatic nerve is a very important nerve, and this, it's one of the biggest nerves on the body, and it supplies most of the lower extremity, especially the posterior part. So the sciatic nerve is a big nerve, takes from L4 down to S3, and goes anteriorly as the lumbosacral trunk, and then goes through the sciatic notch, and then goes over the ischial tuberosity. So there are many techniques to perform the sciatic nerve. So this is the old technique where we, on the old days, we were trained to do this. You put the patient on the side. You find two important landmarks, the posterior superior iliac spine and the greater trochanter. And you draw a line, and in the middle of this line, you drop another line 5 centimeters below, and the sciatic should be there. And you put your needle, and best done by the nerve stimulator because it's a deep block, and if you have an obese patient, it's going to be very challenging. So you use the nerve stimulator. If you have an ultrasound, curvilinear probe would be great, but even with the ultrasound, it's not easy to see. Another technique is the parasacral nerve block. It's more superficial than before and gives you more coverage from the sciatic nerve. And another technique would be the one that's more trendy nowadays, and most of people do it, is the subgluteal nerve block. It's easier than the other two techniques, and the landmarks are simple: greater trochanter of the femur and the ischial tuberosity here, and you draw a line in between them, and the nerve supposedly to be in the middle here. So with the use of the ultrasound, it's easier to see this nerve, although it's still not that easy. So this is what we see in the ultrasound. So these two landmarks we have, the ischial tuberosity is here, and this is the greater trochanter of the femur. And the nerve is between, and this is the nerve, like the compressed wedge-shaped, and you want to see this. So once you see this, you go underneath the nerve and you inject your medications, and you should, and the volume should surround the nerve and should be good. Another approach to the sciatic nerve is you approach the sciatic nerve anteriorly. However, it's still difficult. It's deep, so you have to go through all of these muscles. You have the femoral artery in your way, and you need to use a curvilinear probe. Sciatic nerve has also many variations, so even you do everything right and you miss something, it's probably because it doesn't go we missed it because we didn't see it and we didn't recognize the variation. And another important block that's like very popular nowadays is the popliteal nerve block. It's where you target the sciatic nerve just above the knee crease. Here, like the sciatic is continuing up from the thigh down, and just 5 to 7 centimeters above the popliteal crease, it divides into two branches, the tibial on the medial side and common peroneal on the lateral side. So this is how we do it. There are many techniques, prone, lateral, and supine. The supine is becoming trendy nowadays. You see these nerves next to each other as they are honeycomb appearance. The bigger one's the tibial nerve, and the smaller one is the common peroneal. And you target that nerve, and you deposit the medications there. And this gives you a block from the knee and below. The last one is the ankle block. Is a very important and simple one and can save you general anesthetic and putting the patient to sleep. So there are 5 nerves that are very important for this. So remember, we have 2 malleoli. So you have two nerves in front of the malleoli and 2 nerves behind the malleoli, and one will be covered with a ring block in front of the ankle. So this is the ring block would be superficial peroneal. The deep peroneal is here, and this is next to the anterior tibial artery, which continues to be the dorsalis pedis, and the saphenous nerve on the medial side. And the most important one is this one on the medial side behind the medial malleolus. This is the posterior tibial nerve, and it's posterior to the tibial artery. In front of the medial malleolus on the medial side is the saphenous. On the lateral side, we have the deep peroneal nerve, superficial peroneal nerve, and behind the medial malleolus is the sural nerve. This is the most important one, and this supplies the sole of the foot. This is the posterior tibial nerve. And this is, when you use the ultrasound, it's best if you have this small probe. It helps you maneuver the probe really well. And this is the nerve we target. And this is the peroneal. You look for the artery, the anterior tibial artery, and it's lateral to the anterior tibial artery. And this is the last slide, Dr. Huda. So the tibial nerve here behind the medial malleolus, and this is the tibial artery, and this is the deep peroneal nerve next to the anterior tibial, and this is saphenous nerve. It's doesn't have, it might have the great saphenous vein, and this is the sural nerve, and the landmark here is the small saphenous vein. Thank you.
Thank you very much, Dr. Eman, for this informative, collective lecture about the upper and lower limbs. We have a couple of questions which are relevant to the lecture today. If the attendees would allow, I will skip the questions I thought they are not relevant to the lecture today. So, is interscalene block enough for clavicular fracture operations?
So interscalene is not enough for the clavicular fracture, and especially depending on if you have fracture on the lateral side of the clavicle, so you have to supplement that with some suprascapular nerve block, supraclavicular nerve block, or other nerve blocks. If the medial side, usually it's okay with some subcutaneous infiltration.
One last question, for total knee replacement, a femoral nerve block and obturator nerve block enough, or we need to block the sciatic nerve?
So this is a very good question, and it's a very big room for debate, and it depends a lot on where you practice. So if you're doing only regional anesthesia and you're not doing spinal or general, you have to block everything. If so, the way now it's like that, the trend in North America is to do spinal and to do intra-articular infiltration and to do adductor canal block. But it depends on where you practice, what is the facility like, and now, like sciatic nerve block, the surgeons panic from the sciatic nerve block in particular because it gives them foot drop and they cannot differentiate it from them or from the nerve block. So they hate it. So that's why we have the new generations from the sciatic, which is super selective ones like the IPAC, where you do the terminal branches of the sciatic.
Thank you, Dr. Ken. Thank you very much. Do we have time, Dr. Saad, to catch up with the poll about?
Yeah, absolutely. I will share them now, if you don't mind. This I will share the first poll, Prof. And that's the one here. And okay, Prof. Muhammad, do you see that?
Yeah.
Okay.
No, I
Dr.
didn't.
Eman, can you stop sharing your?
I saw only Dr. Eman.
I will. I'm trying to figure it out. Yeah, stop sharing. Okay.
Okay, I will share that. Okay.
Yeah. Yes.
Okay, do you hear that, please?
This is the first one.
That's the first poll.
Yeah, the first poll is a
Okay.
perioperative pacemaker check within 12
Yeah.
months of the. Yeah. You said
okay.
true. It is true. It must be within 12 months, and the ICD 6 months. So 43% answer it is true. Okay.
Okay.
Regarding an ECG provide information, sure. Patient dependence, I said pacemaker dependence by ECG spikes, everything. So 87% is okay.
Okay. Lovely.
Yes, please. Second one.
Third one. The third question. The rate response function of the pacemaker should be programmed.
Okay. So, sorry, I will check. Sorry.
Prior surgery.
The rate responsive, I said yes. You have to the rate responsive. You have to disable it. It's or 65% answered right. Regarding the monopolar, no, monopolar is absolute conjugates, right?
That's fine. Thank you. I will get the third one now. The second one, sorry.
Yeah.
Okay. Share the result now.
This is a pre-lecture, right?
That's the last one. That's the end. That a patient presented for routine surgery has history of ventricular tachycardia.
Yeah, I know. This is ICD. External defibrillation should be less than 10. No, you said it's more, must be more than 15 centimeter or more. Not because less than 10 centimeter, it will damage the generator and damage the Z pacemaker itself. Okay? Arrhythmia should be treated as following the ALS. Yes, you have to give, even you did whatever the joule, whatever the energy, you have to go right. Okay? The energy output of the conventional defibrillator should be altered? No. As I said, although the ICD, this is a very important point. If you have a patient arrested or something like that and need to, with ICD, it is disabled, you are disabling the ICD. Removed if you have put a magnet or you are reprogrammed. If you are putting a magnet, remove the magnet and wait for 10 to 12 seconds. During this 10 to 12 seconds, this ICD will work. Okay? If it will work, it will give the shock. If it is not effective, you follow your external defibrillator. Okay. If the patient, if this with ICD is reprogrammed, also call for the reprogrammer if it's available within your hand. Okay. If not, wait till 12 seconds, as I said, and then start your check. It will give the shock, or you have to give the shock externally. External pacemaker is contraindicated? No. External pacemaker, it has to be there because, as I said, ICD, with ICD, there is a pacemaker now. So I have to, it is mandatory to have external pacemaker and external defibrillator. The device needs to be checked at the end of surgery. Yes. At the end of surgery, you have to check the device, and the cardiologist or whatever the techniques, IED team, to come to interrogate the device from the start. It must not be done immediately. You can wait for some time, and the patient fully monitored in the post-operative PACU or whatever, or ICU, till the CIED team come. Okay.
Thank you, Prof.
Okay.
Thank you.
Thank you.
Thank you.
Thank you very much. I would like to pass my thanks to our lecturer today, Dr.